Hi everyone and welcome to RaphStats. So this is a lecture series I'm putting together to try and better explain some basic concepts in statistics and how they apply to medicine, because I know this is an area that confuses a lot of students. So I'll try and make it as simple as possible and not get bogged down, because I know people can find statistics really boring. So this is trying to make this an interesting way to look at statistics. So in this lecture, we're going to talk about sensitivity and specificity, two things that do come up in exams, and it is good to get your head around, and specifically about why they're different from accuracy, and then go on and talk about some more complex measures that maybe are closer to our idea of what accuracy means. So our learning objectives are to go over what sensitivity and specificity mean, understand why these are not the same as accuracy, and then understand the definition of positive and negative predictive values, which is something probably closer to what we're thinking of when we say accuracy. We will appreciate that the base rate of a condition is going to determine how accurate our tests are, and then understand a concept called likelihood ratios, which can help us when trying to interpret and make sense of tests. So I think this is something that people can get a little confused about, and whether it's the people who have it or the people who don't. I think the way to think about sensitivity and specificity is that sensitivity is answering the question, can your test correctly identify people who have the disease? And I'm going to use HIV as an example at several points in this lecture, if this patient has HIV, how good is your test going to be at telling him he has HIV? Specificity is the opposite. So it's how well your test can correctly identify people who don't have the disease. So if you don't have HIV, how often will my test tell you that you do not have HIV? Now this property is intrinsic to the test. So the number of people who have the disease is irrelevant. This is something you can calculate as a test-specific metric. This is the classic table in which sensitivity and specificity are presented. You've got the tests that are positive, the tests that are negative, the people who have the disease and the people who don't, and that forms those four interlocking squares. Now sensitivity, because as we said, it's can we identify the people who have the disease? We just want to look at people who have the disease, and essentially we want to look at, of all the people, so that's the A plus B bit, of all the people who have the disease, how many are we telling that they do? How many people test positive? So it's A over A plus B. Because how many people test positive in those who have it versus how many people have it overall. Now, a related concept to sensitivity is the number of false negatives, or essentially you tell them you don't have HIV, but they do. Now this is the inverse of the sensitivity. So instead of A over A plus B, it's just B over A plus B, because it's how many people have you wrongly told that they don't have the disease, but in fact, they do. Specificity is the opposite. So how many people who don't have the disease, the total being C plus D, of those, how many are we saying that they do test negative? So it's D over C plus D. And that's how you can use these four square tables to work out sensitivity and specificity if it ever comes up in a question. Again, for specificity, the inverse is going to be your false positive rate. Or you tell them you do have HIV, but actually you're wrong, and they don't. And again, you're just going to use the other number, so it's C over C plus D for your false positive rate. Yeah, and in fact, it's just the opposite. So if your specificity is 95%, that means that your false positive rate is 5%, 100% minus that rate, and that's the same for sensitivity and false negative. Okay, so that's sensitivity and specificity. That's okay when you're answering questions in an exam, but that's not really what we do in real life. In real life, we don't know whether someone has the disease and then we get a test and then we want to work it out. We know the results of the test, and we want to use that test to make decisions about whether we do or do not think they have a disease. So this is a question to sort of assess our instincts about sensitivity, specificity, and what that means in terms of accuracy of tests. So the question is, if you have a test which is 100% sensitive, so it will pick up every single person who has the disease, and 91% specific. This number is slightly odd for purposes that help with calculations. So of 100 people so it's 91% specific, 100% sensitive, and you have a population, let's say a general population where 1 in 100 people have HIV. you test that whole population, what's the chance that if you get a positive test, you have HIV? And I want you guys, don't try work it out or think too hard about it, just say what your instincts are as a medical student. And I'll give you 15 seconds just to try and think, well, what do you reckon? So we're going to work through this problem and maybe show that what our instincts say isn't quite correct. And the majority of people get this question wrong when asked it, including working doctors. So for illustrative purposes, here's our population. We've got 100 people, and that one dark blue person has HIV, and the 99 people in light blue do not. So this is our 100 people. Now, we know that our test is 100% sensitivity, so we know it's going to give a positive test for that one person who has HIV. So I'll put a little tick by him to show he's got a positive test. Now, we've got 99 people here who don't have HIV, and we know there's a 91% specificity. This is the reason that I chose 91 rather than 90. So what this means is 90 people will be correctly identified, because we're going to correctly identify 90% of people who don't have the disease, 91% of people who don't have the disease, as not having it. And that's 90 out of that 99. So we'll put little red ticks by them to show that they got a negative test. But if you're only correctly identifying 91% of people as correctly not having the disease, that means you're telling 9 people who don't have the disease that they do. So we'll put 9 ticks, green ticks by those people to show that we've told them they have the disease, even though they don't. And now we can break it down. What you're actually going to see as a clinician, you're going to see that those positive tests, so we'll put a square around them, and you can see that of those 11 people who, of those 10 people who tested positive, only one of them has the disease. So actually the answer to the question asked is that if you have a positive test, you've only got a 10% chance of having HIV. This is the classic table in which you might see these results depicted. So again, we've got everyone of the people who have the disease, only one person. We've got a positive test, and all the people who don't, 9 are testing positive and 90 are testing negative. So what we're looking at here is something called like positive predictive value, or if you get a positive test, what's the chance that you actually have the disease? And that's 10%. And to look at that, we look at these columns rather than the horizontal rows, looking at, in those who test positive, how many have the disease. So this is where that differs from sensitivity and specificity. So as you can see, perhaps our instincts about how commonly people who test positive have the disease are not always right. And why does this matter? Well, in real life, it's why it's really hard to screen for rare diseases. 1 in 100, even a really good test with really good metrics, those are really good metrics, your positive test isn't actually going to mean that much. So it's tough to screen for rare diseases. It's also why we repeat COVID tests if a patient is very high risk, even if they're negative. And we'll talk about that a little bit later in the lecture. And it's counterintuitive. So our instincts about how that works are wrong. And basically the reason for that is we need to take into account the background probability when interpreting tests. So as I said, these concepts bring out the positive predictive value and the negative predictive value. So instead of saying, if you have the disease, how many of these tests will detect that you do, this is instead saying a more natural question that we ask ourselves as doctors: what's the chance of you having this disease if you test positive? And that's the positive predictive value. Or conversely, what's the chance of you not having the disease if you test negative? So the negative predictive value. Well, we spent all that time working out positive predictive value, and it's here 10%. So basically, if you test positive, you've got a 10% chance of having HIV. On negative predictive value, everyone who tests negative doesn't have the disease. So it's 100%. So we're 100% sure you don't have the disease if you test negative. And what that means is, for example, here, this test would be a really good rule-out method. If you thought someone might have HIV, you could do it, and you'd be definitely sure that they didn't, and they tested negative. But if they tested positive, you'd need to do more work. You wouldn't be sure that they have the disease. The problem with positive and negative predictive value is they change as the background rate changes. So if HIV was really common, 50% of your population have HIV, then actually your positive predictive value gets much better, it gets much higher, and your, here your negative predictive value stays the same. But if it was less than 100% sensitivity, your negative predictive value would get worse. And that's why, for example, the UK doesn't recommend screening for HIV in all areas. It only recommends screening for HIV if the background rate is high enough. So in those areas where we know that enough people have HIV that the test metrics are appropriate. Now, obviously, if you know the sensitivity and specificity, it's a bit of a faff to go through this process and work out a new positive or negative predictive value based on your background rate. So how do we do this? What's a better way of doing this? The solution to this is essentially likelihood ratios. So instead of saying an absolute value of, let's say, here the positive predictive value was 10%, they'll instead say how much your initial estimate will change if you get a positive or negative test. And this is really helpful because as doctors, we don't just take into account the background rate, we also have our instincts about how likely do we think that this person has a disease. And what this does is it lets us incorporate those instincts and objective evidence from tests into our decision-making processes. Now, the likelihood ratios is based on the odds ratio rather than the risk ratio. And I know that this is something that people aren't necessarily familiar with or comfortable with. So we'll veer off slightly just to discuss the difference between a risk and an odd. So what is the difference? Well, risk is what we think of intuitively when we think of chance. What is the chance of something happening? And that is the chance of an event out of all of the total events that could happen. So to use the weather as an example, if the risk of rain was 5%, we'd expect that out of 100 days, 5 would be rainy. Odds is slightly less intuitive. And this is when you're hearing, 2 to 1 or 3 to 1 odds, if you're betting on a horse or a sports match or anything. This is a metric that is being used. And instead of the number of events compared to all total events, it's instead the number of events compared to not events. So 5 to 100 odds, instead of being 5% odds, that's 5% odds, would instead of being 5 days out of 100 total days, is 5 days compared that it does rain, compared to 100 days it doesn't rain. So if you translated that back into a risk, it would be 5 out of 105. And I've got another work through example here, where 1 in 3 people get cancer in their lifetime. The risk is 0.33 or a third because it's 1 person over the total number of people, 3, whereas the odds is actually 0.5. So it's the number with 1 compared to the number without 2. In contrast, if 1 in 100 births have Down syndromes in mothers over 40, then the risk is 0.01. 1 person has it over 100 people, and the odds are 0.0101. The numbers with 1 over the numbers without, 99. And I guess what you see here is that here, in this really rare event, the risk and the odds are basically the same. We can almost ignore the differences between them. Whereas in that quite common event, so in the cancer example, they were quite different, 0.5 and 0.33. And essentially, that is one of the takeaway messages here. So odds and risks are essentially completely interchangeable when events are rare. But when events are more common, they have big differences. And that's important both in interpreting likelihood ratios, but also in papers when knowing how common an event is. So if, for example, a outcome in a trial is really common, the trial should not be using odds ratios to report them because it's confusing and it's essentially making it look bigger than it is when people are interpreting it as a risk ratio. Whereas when events are really rare, you can just interchange them. You can use odds, you can use risk. Practically, it makes virtually no difference. Okay, back to likelihood ratios after that quick digression. So a likelihood ratio, as we said, is going to take into account that. It's just going to say how our perception of risk changes with a specific test result. And it's specifically going to tell us how much the odds of an event change as a result of a test. The likelihood ratio is saying how much are my new odds comparing to my old odds. And what you generate is two different ones. One, that's a positive likelihood ratio. So if I test positive, how much more likely does that make me to think this person has a disease? Or a negative likelihood ratio. If they test negative, how much less likely is this person to have the disease? And these can be really quite different. So for example, we'll work it through, but with our last test, if someone tests negative, we're 100% sure that they don't have the disease. So our negative likelihood ratio is going to be much stronger than our positive likelihood ratio in the example we just worked through. I'm going to work this through to talk you through how this occurs. So here, the initial odds of a person having HIV is 1 over 99, and that's because one person has it and 99 people don't. And that's about the same as the risk, 0.01. If the person tests positive, the odds are now 1 over 9, or 0.11. To get the positive likelihood ratio, we take the new odds, 0.11, over the old odds, 0.01, and get 11. So for this test, and this is the same no matter what the background rate is, the positive likelihood ratio is 11, and we can use that. In contrast, the odds of the HIV, if the test is negative, is 0. So negative likelihood ratio is 0, so the new odds over the old odds, 0.01, and 0 divided by anything is 0. And what this means is, no matter what the odds were before, we times it by 0, so we're 100% sure afterwards that the person doesn't have HIV. So these are the mathematical formulas that let you work out the likelihood ratio directly from the sensitivity and specificity without worrying about a worked example. I went through a worked example just to make it a bit easier to understand, but we can see here if we use the general sensitivity and specificity that it's easy to find out about a test, we can directly work out the positive and negative likelihood ratios. Don't worry about learning these equations or anything like that. This is just for you to be aware that it exists. Feel free to pause and have a look if you're interested. So we've worked it through and we found out for that HIV test, the negative likelihood ratio is 0 and the positive likelihood ratio is 11. And the use of this can be used to calculate the odds of having and not having HIV after your test, no matter what the background rate or prior suspicion is. And I'll work through a couple of examples actually with COVID tests to show you why this is really helpful. Before we work through those examples on a COVID test, let's just talk through the maths so you're vaguely familiar with how it works. Let's take a new background rate of 2 in 100 people having HIV. To calculate the odds, we take the 2 people who have the disease and the 98 people who don't, divide them out, and that gets you around 0.02. Pretty much the same as the risk because it's a rare event. If it's a positive test, the new odds are those old odds, 0.02, times by our likelihood ratio, which we've already worked out as 11, so 0.22. This means that 22 people with a positive test will have HIV for every 100 without. And converting that back to an easier to understand risk, that's 18%. So if it's too complicated to do that process of working out the odds, there is a shortcut which you can use if your pre-test probability, that means how much you suspect they have the disease before you do the test, is between 10 and 90%. And that's essentially looking at these tables to just equate the likelihood ratios to an approximate change in percentage. And again, you can find these tables online if you need, but it's a useful thing to have a sense for. This test makes it about 20% more likely they have the disease. And this is really important in interpreting tests. This process that we're using is known by another term, which is Bayesian statistics. Now, you can get really in depth about the equations of what this means, but essentially, this is the statistical approach, which resembles how we practice in medicine. And the difference between this and the other branch of statistics is that it incorporates our prior knowledge. We're not going into something blind with our null hypothesis being no different, like in a research trial. We have our opinions before we do this test. We might think this person has almost no chance of having COVID, or we might think we're pretty sure this person does. And what Bayesian statistics allows you to do is combine that initial instinct with objective evidence in order to form your final judgment of how you're going to treat a person. 4 examples of how you might use this in a real scenario, I would take COVID tests. So in Bayesian statistics, it's really important we guesstimate how sure we are before we go in interpreting the test. So in this example, we'll work through a patient with cough, fever, and anosmia. We'll say we're pretty sure, we estimate we're about 80% sure they have COVID. Now, I've given you the figures for the negative likelihood ratios and positive likelihood ratios of a COVID test. You can find these figures online for most tests, and I just Googled to find these out. So the negative likelihood ratio is 0.3, and the positive likelihood ratio is 14. So we're going to look at our tables to make this easy to work out and say that, okay, that negative likelihood ratio means if the test is negative, we're going to take away 25% in the chance they have COVID. Whereas if the test is positive, we're going to add about 45, a bit more than 45%, but we'll just say 45% for convenience sake. So if we're 80% sure, we know that if we get a positive test, we're now essentially 100% sure. That's, you can't go above 100, but we'd be as sure as we can possibly be that this person has COVID, and we'll just accept that as the truth. However, if we get a negative test, we're just going to take that negative likelihood ratio, we're going to take away 25%. We're still 55% sure that this person has COVID. So we're still we more think they have COVID than that they don't. This is really important because this suggests that we can't just accept that negative test. We need to do further tests to try and really work out and make sure whether this person does or doesn't have COVID. And this reflects how good practice works in real life. If you've got someone with classical COVID symptoms, we don't accept a single negative test. We repeatedly retest them at least 2 or 3 times to make sure that we're happy that they don't have COVID. And this statistical approach allows us to objectively see that that's a reasonable approach. In contrast, let's take someone who we were 30% sure might have COVID. So they've got some symptoms, but other things pointing away. Again, we've really worked out our positive and negative likelihood ratios. If they're positive, we're going to add 45%. That's 75% sure. So we're pretty sure this person has COVID, and we can accept that and move on. But now if they're negative, we're 5% sure they have COVID. So we're 95% sure they don't. So here we can see that in this scenario, where COVID is much less likely at the pretest probability, so we think there's less chance, they're like a low risk of COVID, it's much more reasonable to accept that negative swab, and that will be correct in the vast majority of situations. So this is just demonstrating how different likelihoods going in, so your different estimations of how likely this person is to have one disease or the other, can completely change how you react to a positive or negative test. And the likelihood ratios let you make that judgment. So what are the takeaways? Well, likelihood ratios let you take into account your prior clinical suspicion, your background rate, and you can use them regardless of what that rate is to think about how we make decisions in a more objective manner. Specifically for COVID tests, the example we've walked through, this is why we often trust a positive test, but need to repeat a negative test, especially if we're pretty suspicious that a person has COVID. What have we covered besides that? Well, we've gone over definitions of sensitivity, specificity. We've talked a bit about positive and negative predictive values, and also a little bit about the statistical concepts of odds versus risk. We're starting to understand how the limitations of these measures with regards to base rate of conditions require us to sometimes use more sophisticated methods. And we've worked through several examples of why our clinical intuitions might be wrong about sensitivity and specificity, and how to apply the likelihood rate. Just to add, thanks to Manny for help with the design of the presentation. This is a new lecture series, so it's really helpful to get some feedback from you guys, both about what you found helpful, maybe what confusions, what explanations you found confusing, and if you'd like any more topics. This will help me update the slides, make the lectures better, and hopefully provide teaching that's useful to you. So I'd really appreciate it if you can fill out some feedback either by scanning this QR code or by going to tinyurl.com/RaphStats. I will leave this up here for the next 30 seconds or so on the video, just so you have it. Thank you.